That's a good.
Thank you for kind introduction, Chairman. So previous three speakers has discussed about intraoperative and surgical techniques. So now I'm focusing on post-transplantation monitoring and potential intervention after surgery. So for the small pore size syndrome, in large part, it shares the same pathophysiologic process like post-hepatectomy hepatic failure, which both coming from the too much portal flow to the remnant liver or small liver graft, and then causing sinusoidal injury and the liver injury and functional decrease. So many evidence actually coming from the liver resection models. And the important feature about this is that the injury actually starts right very early after reperfusion or resection. So we did some experimental studies comparing the the outcomes after 70% hepatectomy. 70% hepatectomy actually does not kill pig or rat, but even after 70% hepatectomy, there's some significant vascular sinusoidal injury appears early after 6 hours after hepatectomy. So here, and also even after 7 days, from the first week, the injury usually gets worse. And when we did 90% hepatectomy, the ET1, which is the very strong indicator of sinusoidal injury, significantly increases. So very early after resection. So which means the prevention is the most effective treatment actually, because once we reperfuse and once the liver graft experiences very high portal pressure, the injury starts right away. And this is the one of the landmark study and about the minimum GRWR required in LDLT, published almost 20 years ago. Those who received the graft with the GRWR less than 0.8 showed a significantly poor survival. But if you look at the timing of mortality, all mortality case happened very early after transplantation. At the same time, not all patients died either. If patients survived this period, no more mortality was recorded. And this graph shows that portal pressure of patients with a small graft is much higher than the other patient, and easily goes above 20 millimeter mercury. And we can assume that these portal pressure could be measured only in survivors. And portal pressure decreases and becomes similar to other group of patients by 2 weeks after transplantation. So this means that the first 2 weeks is the critical period determining the outcome. And there has been several different definition about small pore size syndrome, and also the small pore size syndrome cannot be simply defined by the graft size. So many other factors have to be considered, and also some clinical factors have to be ruled out to make correct diagnosis of small pore size syndrome. So last year, the there was a consensus conference about small pore size syndrome hosted by ILTS in Chennai, India. And I was honorably invited as one of the member of the working group, which is diagnostic criteria for post-LDLT small pore size syndrome. And there, the Professor Ikegami and the Soejima were there together in the same working group. So we did some literature summary looking at the outcomes of small pore size syndrome. And we first sorted out those literature by the year of publication. And then most literature actually used bilirubin and INR and sometimes ascites, which was measured on day 7 and 14. And then once we sort those literature by the survivor rate, then it was like this. So when we look at the outcome, the worst outcome was about mortality above 50%. And once this is our report, but we applied the treatment for those patients which graft survival there was no mortality from the small pore size syndrome, and so we could stratify the publications in 3 different kinds. So from these table, Professor Ikegami and I drew this table. So there was a definition, and a new definition and grading system was proposed. And grade A was considered pre-small pore size syndrome stage, and post-op day 7 and 14, the total bilirubin of 5 milligram per deciliter, or ascites more than 1 liter per day, was considered as a grade A, which actually is expected to have a very similar survivor outcome compared with the group who did not have a small pore size syndrome. And there's a grade B, which is portal hypertensive phase, and bilirubin over 10, and or INR greater than 1.6 on post-op day 7, and or on post-op day 14, both total bilirubin and ascites 1 liter per day. So in this situation, inflow modulation and medical care is strongly recommended. And if the bilirubin greater than 10 and INR 1.6 on day 7, or bilirubin greater than 20 milligram per deciliter, is expected to have a very high chance of graft loss, and possibly retransplantation may be considered. So after the literature review, we determined that this level of evidence was moderate, and the grade of recommendation was also moderate. And this consensus meeting was summarized and published last year in the Transplantation. And there's a, as you can see, the definition itself is static determination from the laboratory result on day 7 and 14. So it does not say about the trending of the laboratory value. So we had some question: what if the lab value was uptrending or downtrending? Then would that the result can be different? So we did some multi-center study, and the basic idea was in regarding the grade A patient. If we separated three groups as an uptrend group in the laboratory value, or downtrend group, and some ascites only group. So, like through the ILDLT platform, 12 center was recruited, and for the control group, for high volume center provided comparison data, and then the uptrend group had there was a significant difference between the total bilirubin. The uptrend group had increasing bilirubin comparing to 5, 7, and 14th day, and the downtrending group had this pattern, and the ascites only group did not have a significant change in the lab values. And looking at the complication rate, there was a similar rate of complication, but 90-day mortality was significantly higher in the uptrend group. So looking at this survival graph, there was no significant change in the overall survivor comparing small pore size grade A group and the non-small pore size group, but the uptrend group had a significantly poorer survival outcome even within the same small pore size grade A. So, but looking at just the GRWR, there was not much significant difference among the GRWR. So GRWR itself is not a single important number. Overall, the trend may be more important. So once we did the Cox regression analysis, the most important factor was trend of those laboratory values, and age over 65, and MELT greater than 30, and the ABO incompatibility. So if the patient has a risk factor more than 2, then the outcome was very poor compared to other groups. So which means that even though small pore size grade A, if the labs were getting worse, then the outcome can be jeopardized. So this subgroup should be considered differently, which maybe in the later can be shifted to grade 2. So far, I just talked about how we diagnose and grade small pore size syndrome, and after that, what can we do to treat those situations? So there was two different studies so far. The first one is also run by the ILTS, which was the ERAS-4-OLT working group, and after that, also the last year consensus meeting, there was also subgroup of management of established small pore size syndrome in post-living donor liver transplantation. So mainstream of the treatment after the surgery is the splanchnic vasoactive agents such as propranolol, somatostatin, or terlipressin. These drugs are routinely already used for the prevention and treatment of GI bleeding due to portal hypertension. And these medication can induce splanchnic vasoconstriction and with the minimal influence on systemic circulation and potentially decreasing portal flow and the pressure. So there was some initial clinical experiences very early in 2000 about the anecdotal experience. But we also reported some our experience of propranolol combined with splenic artery embolization. And regarding somatostatin, Professor Troy's group run the randomized trial comparing the not really the effect of small pore size, but rather focusing on the safety and feasibility about the somatostatin, which was proved to reduce portal venous flow and hepatic venous pressure gradient, and also it can increase a little bit about the hepatic artery flow by buffer response. So the safety, I think it's proven, but so far not many papers really reported about outcomes. It's very difficult to do a randomized trial about the effect of this medication on the small pore size syndrome. So most of the study has to be probably retrospective study. So in those consensus group meeting, so the recommendation is somatostatin. The early intervention with the somatostatin might be considered to decrease PVP in patients with small pore size syndrome. The level of evidence was moderate, and the recommendation was moderate. And after that, the proximal versus distal embolization of the splenic artery can be effective for the grade B small pore size syndrome. And also, this level of evidence was low, but the strength of recommendation was moderate. And for grade C patient, the recommendation is retransplantation is recommended. But, if we measure portal pressure and flow in the OR and during the time of transplantation, and if we think that there is a significant hyperperfusion to the small graft, then I think splenic artery ligation may be the first thing that we can try. And if it was not done in the OR, then I don't think we'd lose much by just simply applying interventional radiology and splenic artery embolization. So this is our institutional protocol, which was published in International Journal of Surgery 2 years ago. We apply two-step portal flow modulation strategy. So if we are dealing with the small graft, then we measure HVPG, which is we puncture portal vein after reperfusion, and also IVC, and compare those two pressure difference. And if HVPG greater than 10 millimeter mercury, and at the same time, portal flow is greater than 3 times of graft weight, then we just ligate the splenic artery first. And then after surgery, if there's any suspicious signs of small pore size syndrome, such as increasing bilirubin or INR does not increase or significant amount of ascites, then we use somatostatin. And then those splenic artery ligation was more frequently performed in the left lobe graft group, and 5 patients received IV somatostatin after surgery. And fortunately, we have not lost the patient from the small bore size syndrome, even though we used many left graft and the small bore size graft. So in summary, so injury starts early after reperfusion, so prevention is the best. And consensus-based definition of definition and grading is available. And the total bilirubin, INR, ascites are the parameters used in the diagnosis of small bore size syndrome. And somatostatin, terlipressin, splenic artery embolization are the main option that can be used after liver transplantation, and prospective validation is required. Thank you very much.